Hello, everyone. So I thought today would be quite helpful just to run through what's currently happening in terms of a national policy update across the NHS, and then to have a look at one of the main issues now that is having to be addressed, specifically with regard to the development of integrated care systems, which is how providers work together in effect. So whether you call it provider collaborative or alliances, not really too much of an issue from a legal perspective, but how you actually come together and work together is, because of the various legislation that is already in place. But to kick off, I thought would just be helpful just to let people see what's been happening post-COVID, because there's been quite a lot of developments. Just on a national policy update and what's been happening. So anybody working with commissioners will know that there is new guidance out now on constitutional change, merger and dissolution. Generally, it's being used by those CCGs which are going through a merger process at the minute. To be honest, it's not too dissimilar from the guidance that it's replaced. It just adds a bit more context, I think, with regard to how the mergers will actually go through. My understanding is that whilst integrated care systems need to be set up by April 2021, it's kind of accepted that hopefully we'll get most CCGs through merger proposals they have, but that it could take a bit longer. I think everybody is kind of just looking to see how everything settles down post-COVID with what's going on. The other new document which has come out, which I think has been waited for a little time, given the last one and where we were with it, is there is new who pays guidance. It's pretty new out. It's only been out for a couple of weeks. My team did help NHSE on it and give the legal input. Although, as with every document like this, you just think you've put it to bed and then somebody decides to bring a judicial review against the Secretary of State over his determinations with regard to the provision of Section 117 Mental Health Act aftercare and where somebody is resident. So there may need to be a tweak yet. As I understand it, that case is now going on appeal. So we will be watching that. So that is something just to watch out in who pays. But the interesting thing, I think, with this edition of who pays is that it actually does what it says it's going to do in terms of statute. So it does tell people who the responsible commissioner is, but then NHS England do also use their power within this version to indicate when they think the responsible CCG for paying will be different from the responsible CCG for commissioning, which hasn't really been done that much in the past. So what they're trying to do is make sure there's equity in that regard, and that CCGs don't inadvertently manage to reduce their costs through, people moving outside their boundaries or whatever. So that's the purpose behind that. That's out, and no doubt there'll be lots of comment on it as we go through. NHS E&I are going to have some webinars, and we're also, Brian Jacobson, going to be doing some seminars on that as well, on webinars, just to help people understand what the main points are within it. I think probably one of the other main points to mention within the new guidance is that it is seeking to reduce the extent to which you spend money on legal challenges. May sound a bit odd for a lawyer to be saying that, because that's obviously how we make our money. But what it seeks to do is basically make sure that differences of opinion between CCGs go to NHS England for determination and aren't played out in the wider legal arena, and certainly not within the courts. So it is worth just looking at that and understanding that, I think, in terms of going forward. At the same time, and given the changes that happened as a result of the COVID pandemic and the introduction of the Coronavirus Act, which did two things. So firstly, it effectively disapplied the normal process for the NHS to undertake CHC through the application of Section 14 of the Coronavirus Act, which meant that patients didn't have to be discharged, didn't have to be assessed prior to discharge from hospital. Instead, it introduced the new process of discharge to assess, so that you discharge the person, free up the bed so that you can have other people in there, and you assess once they're in the community, having given them a level of care already to make sure they can go there. The second thing the Coronavirus Act also did, which fits into CHC, is that it enabled local authorities to apply easements over their obligations under the Care Act. In effect, it allowed them, if they wanted to decide they weren't going to fund specific care. Now, none of the local authorities, so far as I'm aware, ever did that, and in fact, very few really applied the easements. But that is still there, so it's still currently law within the Coronavirus Act itself. But as we come out of the immediate COVID pandemic issues, then the DH want to change the process, because under the old process of discharge to assess, they were basically giving the money for that to the NHS and to the local authorities. So now they want to go back to the process of the NHS and local authorities being responsible for paying. And to do that, they have introduced a new policy model, which again is a discharge to assess model. And in effect, the expectation is that CCGs will now start assessing properly for CHC and for funded nursing care. Although we have discovered that round about only about 25% of referrals are ever eligible for CHC, which means that I think in the future, and as we move forward, because the underpinning legislation for CHC will need to be amended, some thought will have to be given to how the bureaucracy created can be reduced, and how the service can actually focus on addressing those who are eligible, as opposed to dealing with all of the issues for those who are not. Because, to be honest, there is a bit of a mini industry around challenges as well over CHC decision making. So there is quite a lot to look at with that in order to try and streamline the service, and then to fit it in next to social care. I think the other part to that is obviously how health and social care interact is an important factor from an integrated care system perspective. And I think that the COVID pandemic has also shown us that there needs to be a bit more thought about that. There has been clearly issues with care homes. I think everyone fully expects there will be a public inquiry at some point in the future, and that care homes will be prominent within that in terms of how they fit within the kind of national health and care service that's now being provided. So I think there will be more on that in the interaction. But equally, a lot of that could actually come through the policy in terms of how integrated care systems and at place level integrated care partnerships will operate and work together. And that does inevitably lead to something which I think has been in a bit of the sector press. Certainly I've seen it in HSJ and NHE and a few other publications about the DHSC now thinking about who should really be leading on social care. So should it stay with the local authorities, or should we look at moving it over to the NHS? What is going to enable the system to operate in the best way? I think in order to do that, we need to have a bit more clarity over social care and what the plan for it is. We're still waiting for a white paper on that, and if we could get a green paper, that'd be even better, in order to really understand, so what's the intention, what's going on here, where are we going with it. The other issue which has arisen quite clearly from the whole COVID pandemic is how services should actually be delivered and configured going forward. So we've all now seen the benefits of technology, and how using your phone or your iPad and using whether it's Zoom, MS Teams, or whatever it is, whatever digital platforms available, can actually very much improve firstly your ability to access care, but secondly also to keep people safe, especially when they were shielding. So that is going to figure quite significantly. I think, digital was always part of the integrated care system project, but it will figure even more significantly now, I think, going forward. And equally, now is a very good time to start looking at the NHS estate. So we still do have this connection, which local people and campaign groups have to bricks and mortar. I do quite a lot of service reconfig, and so does my team. And without being difficult with campaign groups, we do say to them, it's not bricks and mortar that provide you with the care. It's nurses, it's doctors, it's clinical staff, it's the healthcare professionals. And the reality is, if you want to have the best care, you have to enable the NHS and allow the NHS to work out what's the best way to do that. So spreading them thinly is not a great idea, because they can't manage in that way. Whereas allowing them to work together without causing unnecessary problems, because you would like to have care closer in terms of your local hospital stay open, is a much more sensible thing, and work with them, co-produce what you think your local service should look like. So there is a lot of work, I think, going to go on around that. We've been in several systems just doing a quick review with them. And what this has also led to is that, so NHS England did commission and send out a kind of guide. It's as I say, it is just a guide, just something to try and help people looking at service reconfiguration. But actually what they've now decided is we need to go back and look at the planning and assurance guidance, and we need to make that much clearer, because when people are challenged, they do rely upon it, and the courts seem to like it. So we're just about to start working on that, which will include a kind of review of, so what have the cases said, what have the recent cases been on about, and where are the key issues that arise. A lot of key issues will undoubtedly arise around equality. The NHS has two equality duties in effect. So one is the public sector equality duty, and the other is the duty to reduce inequalities of access and outcomes. Both are must-dos, which is something that I think has taken a little while for people to understand. It's not an add-on. You must take them into account whenever you're making a decision. So those are bits that will definitely be coming through, and you will see that probably the new guidance won't be around until 2021, but it's going to look to streamline the whole process again as well, in terms of developing your case for change, going through the PCBC process in order to go out to consultation, but then moving through into being clear on capital needs, full final business cases for developments, and all of that. So the process is one long iteration, as opposed to chunked up into small parts with different bits looking at it.
Hi, Gerard. Sorry to interrupt. It's just done it. Are you okay to knock the presentation slide down a couple? I think just had a couple of comments that were still on the opening slide.
Oh, because mine's on the right slide.
Oh. Well, that's Teams for you.
Okay. Does anything happen if I do that for people? No.
Doesn't with mine. Don't worry. We'll.
Okay. I mean, people can have the slides. There's not a huge amount of writing on them.
Yeah, I can. I'll ping the slides out. I'll ping the slides out to everybody.
Okay. Do that.
Cheers,
and then I'll tell people what we're on. So if anybody getting it, we're still on slide 1, which is called National Policy Update ICSs, but not the picture one. So the last bit just to mention is about new statutes. So we currently have the Coronavirus Act, which introduced a number of emergency provisions in order to allow the government to address the pandemic. That will have to be amended, and that will include revoking some of the parts within it. So Section 14, which addresses issues over continuing healthcare in the NHS, we'd fully expect that to be revoked fairly soon. But there are various other bits within it as well, which will need to be revoked and or amended in order to enable us to kind of move forward. We also do, as I'm sure some people will be aware, have some fairly clear emergency functions, which were issued, emergency function directions issued by the Secretary of State, which essentially allow NHS England to, so originally allowed them to make decisions over the provision of independent healthcare in order to support dealing with COVID-19, then allowed them to make wider commissioning decisions of CCGs and take on their functions if necessary. I don't think they've done that very much, but it did give them that ability if they needed to do it for a national approach. Also allowing them to take on functions from NHS foundation trusts and trusts if necessary, and providing them with the ability to exercise some of the Secretary of State's functions if necessary. They currently all expire on the 31st of December 2020. It may be some will be continued into 2021, we're not sure, but it is worth just watching that and checking what happens, especially around the commissioning of independent healthcare. There will also be an amending NHS Act at some point. We need to do that because I think, as everybody probably knows, certainly anybody who's heard me knows, that we currently have a integrated care system policy and objective which doesn't sit neatly or well with the current legislative framework for the NHS. They're very different in their approaches, not the least of which is that the new approach very much looks at integration, including commissioning and provision, whereas the old approach under the Health and Social Care Act introduced by Lansley was very much about we're going to separate commissioning from provision, and the two are going to be very separate. So we need to address those issues. So there will be an amending NHS Act that will introduce various new bits, but I think probably the key issue that most people are looking for relates to, are integrated care systems going to be given any form of legal footing? So currently they are a policy as opposed to a statutory concept, and so they don't have any, they're not a legal entity. That makes it very difficult for them to exercise functions because you need some form of legal entity to exercise a statutory function. So I think some of us have wondered whether or not there would be a kind of top-down reorganisation. I don't get the feeling that's really what the government would want to do. They've done one as a result of the Lansley reforms. I don't know if they'd be that anxious to do another one straight away, but this is just speculation by me, to be honest. We have also suggested that one way through this would actually be to look at the concept behind health and wellbeing boards. So health and wellbeing boards are statutory boards, but they're hosted by a statutory body. And you could, of course, do that. So you could have an integrated care system board, and you could have that hosted by either a CCG or an NHSFT or NHS Trust within the area which it relates to. And that could then take on some functions. You could be very clear over what those functions are, but that may be a neater solution currently, and would also fit with the whole concept of, you know, the kind of devolution with a small d of pushing the decision making out into the regions and to allowing them to work out how do we want to actually fulfill the objectives of the long-term plan. So we'll see whether if that's what happens, but there will undoubtedly be changes to how the NHS currently operates, and they are needed in order for that to work properly. So I'm going to move on now to what I think is numbered slide 2. It's actually my slide 3, if you ignore the nice pictures. So an update just on integrated care systems and where we are with them. So as I'm sure you all know, functions in an integrated care system, we have two types of functions. We have the statutory functions and we have policy functions. And we've been doing a lot of work with systems around, okay, so what does that actually mean? How are you going to look at exercising those functions? So statutory functions are going to have to sit with a statutory body that has responsibility for them. They have to exercise them, but they can ask others to help them to manage them. And so within that, we have looked at, so what is strategic commissioning? And then at a place level, what is an integrated care partnership approach? How do you do that with a provider alliance collaboration? How does that then fit into the place-based commissioning functions, which still sit with the CCG? And what's the role of the PCNs and neighbourhoods and all of this as well? So there's quite a lot to work through. I think, to be honest, we have done a lot over commissioning, certainly with CCGs, and equally in some systems with the local authorities as well, in terms of being clear over what Section 75 arrangements are going to be in place. We haven't done so much on provider alliance collaborations, and there's going to be a need to do more work on that, because whilst place itself and the concept of it, the kind of place partnership board involving the local authority, the CCG, the providers and other, voluntary sector, third sector organisations, has worked quite well in many instances. What we haven't done is really being clear over how do we expect providers to work together. And providers are definitely the other side of the coin, because you can't commission an integrated care contract unless you have a provider who can take it on. And the expectation is that the amendments to the NHS Act could well indicate that only a NHS trust or NHS Foundation trust can take on an integrated care contract. It would also have to go through the ISAP process as well, which means that it's a little bit more involved in terms of what's happening. So we'll come on to a bit more about provider collaboration and alliance as in the next part of the talk. The other thing that still needs to be worked out to some degree is how is regulation and accountability going to work? So is this going to be regionally based with NHS IMAS having an oversight role on a national basis? Will it be expected that an ICS will monitor and regulate how its constituent statutory bodies and other parts of it operate, and seek to make sure that it meets the expectations under the long-term plan and the local plans? I think all of that is expected in terms of how it will operate, but there has to be some clarity and some consideration of, so where there are statutory functions that are therefore being operated at a more regional level, how does that all work? We clearly have system by default, which is a movement away from central decision making. My view has always been that this does kind of follow a devolution type approach. So I've had various arguments with people over this, but I think the reality being that George Osborne and David Cameron's original concept of devolving out health, social care, and basically most public authority functions didn't really take off. So Manchester took it, London has to a degree, but didn't really, I think, take off in the way they had hoped it would. But I think in terms of health and social care, then the 5-year forward view and the long-term plan do follow that kind of concept of let regions make their decisions and not be having to follow constantly guidance issued by the centre. So I think we'll continue with that going forward, and that should enable a more focused regional approach, but also within the region should enable consideration to be given to what places need. So it depends on the nature of your integrated care system region, but most have 2, 3+ places that may have different needs, and they may look at how they actually provide for their health and social care needs of the people in those areas in a different way, whilst having an overall strategic approach for the system. So that is what should be enabled to happen. But I still think we have a bit of a way to go to get all of that governance in place, let alone starting to get it going forward. Backlog, people are looking at the minute to see, so we know we have a backlog as a result of COVID-19. Will that mean that the backlog is the responsibility of the system as opposed to the responsibility of individual organisations? And that would certainly make more sense if you are looking to get integration and have regional regulation and accountability, that you would get people to work together to address backlogs as opposed to trying to individually sort them out. So it will be interesting to see where we go with that. Money is always a more difficult concept to look at. So one of the things which we've said to a number of our clients you need to start thinking about is, how is the money actually going to flow? So if we have whole population budgets and we have integrated care contracts, then you can't just hand all the money over to a provider alliance, because what you have to be clear about, and what the commissioner, the CCG and the local authorities will still have responsibility for is the individuals who need to access the services which are commissioned under that money. So what about acute, community, mental health, primary care? How are you going to make sure all of those are properly provided for and properly financed, as well as making sure you still have sufficient to deal with CHC or with, extra contractual referrals that are going on, or people who decide they just want to go abroad for treatment, all of which is they're allowed to do. They just have to make a request to the CCG and go through the formal processes. So there's quite a bit to look at over that and how that will all flow. And then equally, I think within the actual provider alliances, how are they going to make the money work and how are they going to pay it out? Because tariff isn't going to work. People are going to have to look at risk and gain share and how they're actually going to manage the whole processes. So there's quite a lot to go on the money side that needs to be worked out. And then just to round this bit off, there's also quite a bit, I think, as I said before, to do on statute and policy, so that we're very clear as to what is the role of an integrated care system overall within the NHS, and what functions does it have, and what does that mean for the other statutory bodies or for this current statutory bodies that are there. So quite a lot to look at, quite a lot to do in that regard. I don't know if anybody has any questions on that bit. If you do, I'm quite happy to answer them, or if not, we can move on to the next part of the presentation, which is about ICS providers, alliances and collaborations.
Thank you, Gerard. It's just done a couple of them, a couple of questions in the chat as we've gone along, so we can start with a couple of those if that's okay. The first one was around if there's a move to reduce the number of court cases, would this mean we will have greater flexibility to settle claims locally?
So I think ultimately, if you can do local resolution, that's ideal. But if that's not possible, then I think the aim is that there shouldn't be court cases, and that NHS England will try to support the development of a solution that all parties can sign up to.
Right, fantastic. Thank you. Moving on to the next one, which says, doesn't the NHS also have a duty to ensure we comply with the HRA, thinking particularly from a MCA/MHA perspective? Lots of acronyms in that one.
Yeah. Yes, is the long and the short of that. I think that, so, I mean, we are waiting for some changes to the whole DOLS process. And we know, they were supposed to come roundabout now, to be honest, but that's all been delayed because of COVID. So we'll see that coming through. I think, around MHA, we've also always seen issues have arisen over that quite often, to be honest, around the kind of responsible commissioner. Hopefully most of those are now addressed in the updated who pays, but all of those obligations are still going to apply, and they will inevitably, I'm afraid, will lead to challenges, which is why we have a very specific court to deal with them, generally called the Court of Protection, for those who don't have capacity.
So sorry, Danny and Gerard, I guess it's mixed up here. I posed the question, and I posed it, I guess, particularly in view of your comments, Gerard, about 117. Mm-hmm. I'm thinking about how there might be implications for right to life and right to family life, particularly where there are issues around deciding who pays for where somebody's placement might be.
You're right there, and we've had those issues before. We had a lot of cases based on the Human Rights Act, to be honest, around eating disorder cases, because there were so few places, and sometimes people were placed many, many miles away from where they live, and so that is an issue which I think will have to be considered in terms of, okay, so what services are available regionally? What are you providing for? And equally, that is going to cut into the concept of, well, who's going to commission specialised services going forward? So is it still going to be NHS England, or are they going to look for a more regional approach to it, which would then help to address some of the issues which kind of rise over the Human Rights Act and where people are, especially from an MCA and MHA perspective? So that they're still all going to be there. They're not going away, but I don't have any clearer idea of what the central view is on how that will be dealt with at this point.
Okay, thanks.
Brilliant, thank you. I think that was all the questions in the chat. Does anybody have any other questions before Gerard moves on to the second part, other than what might be good, Gerard? Is there a chance you'll be able to unshare your screen and reshare to see if we can get the presentation back up and moving again?
Yep. So, see, does that?
If there's a share presentation option, I've been told that I'm not an expert in this myself. So, but if not, we are emailing, just so everybody knows, we are going to email the presentations out to everyone now. So look out for that coming through.
I usually find if you share your desktop, Gerard, rather than the actual presentation, that might be the best way. I understand you obviously might have confidential files open. If you close all those down first. I have just emailed the presentation out to everyone as well, so if you don't have it, just drop a message in the chat and I'll make sure that I send you it.
Yeah, sorry, my system definitely didn't like me doing that because it kicked me out.
Oh, well, do you know what, Gerard? Don't worry about it. Just share what you shared before and that will be fine. And yeah, like I say, everybody should have it now, so actually people can go through it home along with you, if that's all right.
No, I've shared the wrong screen now, haven't I?
Oh, yeah.
Hold on.
That might be a desktop if you open up the PowerPoint from there now.
Yeah. It came up before.
Gillian, Gerard, it's Gillian at NHS England. Can I chip in while you're trying to sort that out and just respond to the question that was raised about? There were two questions. One was in the chat box, which was about the timing of legislative change, and as ever, that is in the hands of Parliament, not us. But at the moment, we're thinking that it's likely to be early next year. But the second point was really about the local resolution, and what I would say is, the aim and hope with the revised who pays is that there will be really great efforts to resolve these things locally. We don't want lots and lots of people coming to the relatively small NHS England team to sort out local disputes. That will be the backstop, instead of hopefully going to external lawyers to potentially litigate, but really we would urge everyone to try and be as cooperative and sensible as possible. Now, I know that it's the hard cases and it's the expensive cases that end up in these sorts of disputes, but you know, great efforts would be much appreciated to try and sort them out if at all possible.
Right, have I got the thanks, Gillian. Have I got my slides back up?
You have indeed, right, Gerard. So yeah, no, I think we're good to kick on to the second part. And like I say, anybody who can't see anything moving should have them locally.
I'll be sending out a request for confidentiality to everyone afterwards in case you saw anything. I don't think there is anything exciting actually on my desktop.
We saw your IT help desk number. I think that was about it, Gerard.
I'm constantly ringing that, as you can tell by my inability to make it work. Right, so provider alliances and collaborations. So this has been something I've been saying to people for a while, that we've done part one of starting ICSs. We haven't done part two, and part two is the bigger bit. Part two is the bit where we can get the providers able to meet the expectations, because it's not really what they're set up to do. So there is a new kind of policy context, I think, from NHS England on this, which is about being clear on, you know, what is your offer What's your offer to the local population and place and system? Because that's what they want to understand. They want to understand what are the benefits, what are we getting from this? And I think one way to look at it is that, kind of system. What we will look at is provider collaborative, which will probably address some of the stuff over specialized services, over whole system-wide provision and system working. And then in place, I think it's just easier, although in some instances we did call them provider collaboratives, to call them provider alliances. So it's just easier when you're talking to people to differentiate it out like that and talk to them in that way. The system offer, as I say, is that everyone should be entitled to access full range of high quality acute hospital and mental health services. So, it's very high level, quite strategic. That's what we expect. But the place offer, and this, when you look at it, it's a little bit like starting to look back at the kind of offer that's in the NHS Constitution and comes through the memorandum from the Secretary of State. So access to clear advice on staying well. Access a range of preventative services, so very much looking to pull in not only the duties of the NHS, but also the duties of local authorities around public health. Access simple and joined up services for care and treatment when they need it. And that's going to be key, because essentially what providers will be asked to do is to manage the way that, a patient runs through the service, or a citizen goes through the service, if you want to take them all the way from their provision of care at a primary level, well, at a public health level through into primary care, but then potentially out into a social care setting. So that's quite a lot to ask for. So it's quite an American concept, that, in terms of, the whole way that care is integrated in that way, and the way that that's been done in the past. That the vulnerable and high risk are entitled to simple active support to keep well, and that the NHS should be actually part of their local communities through, those very clearly through employment, training, procurement, volunteering, and play a full part in the social and economic development. So that's quite a high level plan in terms of what's viewed as system in place. But some of the stuff we have to look at, and hopefully some of the stuff that will come out as a result of the changes eventually to the NHS Act, are some of the barriers that are created through the way we've set up statutory bodies. And I don't for 1 minute suggest there's anything wrong with how they were set up. It's just that when you want to change how organisations work together, then sometimes the very thing you did to set them up, which made them different, which enabled them to work in the way that you at that point wanted them to work, causes difficulty when you want to change how they work together. So we know that ordinarily an NHS body operates as an autonomous body that is independent and makes decisions by itself. And, statute very clearly sets out the functions that CCGs have, that NHSE has, that NHSI has, that NHS trusts, foundation trusts, just about everybody out there, Secretary of State has. It's really clear about that. And the general rule is that one NHS body cannot make decisions for another NHS body without that second body consenting to it, or there being other exceptional statutory authority. So it is possible, for example, for NHS England to direct CCG-A to take on functions and make decisions for CCG-B. It's very exceptional, very unusual. I'm trying to think if it's actually been done. Gillian will probably tell me it has been. I can't think of an example off the top of my head where that has been done. But actually I can think of one. But that is quite unusual to happen, because each body is autonomous. And the Act really controls how an NHS body, though, could ask another statutory body to make decisions on its behalf, and when it's lawful to do that. But equally, when it would be, and if it's not done in that way, then it would be ultra vires. And you do occasionally see that at a kind of low level. So the most obvious bit is when we do service reconfiguration, CCGs commission certain things, they should make the decisions about that. NHS England commission certain specialised things, they should make the decisions about that. You have to be quite clear as to who is making what decision, because you can inadvertently, if you're not careful, have a position whereby the wrong body could be making a decision. We haven't got to that point. We've always sorted it out so far, but that's the kind of thing you just have to be careful about, and that's because of the way that the NHS Act is currently made up. But when we look at trusts specifically and FTs, so they both have boards of directors, they're the principal decision makers. Boards can delegate decision making only as permitted by the NHS Act, and that's normally set out in the schedules. NHS trusts have a wider ability to delegate, to be honest, than NHS FTs, so can delegate to individual EDs and to NEDs and to committees. The interesting thing with committees is that there's a wider scope for who can sit on those committees. But NHS FTs don't have that whole scope for delegation at all. So they can delegate decision making to individual exec directors and to committees, but the committees have to be made up of exec directors. You can't do it to individual NEDs, and you can't do it to people who aren't exec directors. So there's no breadth of approach that you have for NHS trusts. And the other thing that they have to be careful about is not delegating to third parties, or how they set up, and the ability to set up joint committees is not there either. So often with when NHS trusts and FTs are in a merger scenario, you may see that we use committees in common, which is not a statutory construct, which is a kind of common law approach to enabling the system to work together and make decisions. And the Secretary of State also has an ability to direct NHS England and other specified bodies to exercise any function conferred on another body. And in fact, you've seen that. So we have that at the minute, in that NHS England do have the ability purely on providers to make decisions for NHS trusts and NHS FTs. I don't think they've used it. Can't recall them using it specifically, but they do have that ability as it currently stands. So that comes from the Secretary of State's emergency powers, though. So he has very clear emergency powers that he can use during the pandemic. So there are various ways and means, and it may seem quite an open system, but the real problem in terms of the integrated care system approach with providers is this difference between NHS trusts and NHS FTs. So when it comes down to us trying to bring provider groups together in integrated care systems, and especially in place, so around provider alliances, then the main things we're looking at with people are people and roles. So relationships are still the key part to this, because we don't, the statutory levers are not aligned with the system that policy wants. So you have to rely on people working together, because as we've just shown, the way that trusts and FTs are set up is very much about autonomy, and about having their own sovereignty and making their own decisions. So to make integration work, then we need to have that sharing, and we need to have people actually looking at how they do it, and that can include mentoring relationships or secondments. Joint posts do work quite well because they bring that together, and shared leadership, which we've seen and can have a look at later on. Governance as well. So we kind of go through, and what we're going through is that, so we have informal governance arrangements where people will talk together. They may then create their own forum. We may move on to committees in common, which may be very specific, but then eventually full in terms of this is really how the boards are doing business. And ultimately that can lead to merger. Or you can have different mechanisms by which they work together, which are through MOU and an alliance, or a gain share, contractual joint venture, corporate joint venture, or management support agreement. So there are lots of different things which we are going to look at some of the examples, but one of the bits we constantly have to be careful about within this is that we still have procurement and competition law obligations. And whilst they've been relaxed to some degree during the whole period of COVID, they still apply. And we still have to be careful that they are not inadvertently breached. And whilst I don't for 1 minute expect any NHS or public authority to be bringing a claim, we have seen some claims brought by the independent sector. And I think generally just because they want to know what's our role in all of this, what is happening, why, can't we go and get this contract, or why have we not won this contract? And their concern is they don't necessarily now clearly understand the rules of the game, and they want to understand what those rules are. And that definitely becomes part of the whole provider alliance part of, so what is their role in this going forward? So if we just quickly go through the kind of the multi-organizational group structures. So just mentioned MOUs. They can be very specific over what you're doing, or they could be quite wide. Their problem is they're not legally binding. And normally the second paragraph in them is these are not legally binding. So it's quite loose, and provides people with an easy ability to leave. And I also, so if I'm really honest, I think we have lots of MOUs. They're written. They take a while to sign, and then how many people actually look at them again? Only normally if you have a problem. So in most of the systems we're working in, we're creating an integrated care system handbook, which is in Word, some of which is legal, some of which isn't. The systems will own it. They will be able to change it. It won't be as onerous to change as an MOU. So some systems will have those in place. There's a joint management team. So, we've got clear examples of that. Mid and South Essex is one example, Royal Bournemouth and Christchurch. We just use these examples because we've worked on both and worked with both teams, so we understand how they work. And they've worked quite well. Mid and South Essex has now completed its merger, but before that, was able to take itself through a whole service reconfiguration process and start to look at how it's going to work together. And Bournemouth and Christchurch have done, and Poole have done exactly the same, in terms of looking to align themselves and make themselves more efficient in how they deliver care. But the one thing is, with the joint management team, you have to remember that the actual statutory bodies still remain independent. But the people enable you to make the decisions together. Alliance contracting, we've seen alliance contracting that's been used in the past. It's normally kind of quite specific when it relates to overlapping service contracts. But the way that alliance contracting has always worked in the past is that we've had quite clear commissioning of it, whereas that's not really what's anticipated going forward with an integrated care partnership. That will be more about provider alliances, so not about just looking at a contract, but looking at how you as organisations work together and what you're going to do. And there are various examples of that. We've seen South Yorkshire, the Healthier Wigan Partnership worked in. The one Croydon Alliance is the one, to be honest, that quite a few people are looking at, Croydon overall, and how that all works together, because that seems as if it is very much starting to fulfil and work along the lines that are envisaged in the long-term plan. Lead provider, so we've seen that with Salford Integrated Care Organisation. It's quite, I think lead provider is probably closer to the concept of a provider alliance or collaborative that we're kind of looking at. The interesting bit will be whether or not the lead organisation can really make itself the integrator of the service delivery so that it works fairly with all the other providers within it, and make sure everybody gets a fair share of the services and the provision and the money going forward, because it's not really the way that we've worked in the past. It's a lot more similar, I think, to the kind of American system and the stuff that, I don't know if any of you looked at what Centene did when they were in America before they came over and worked in the Nottingham area, but quite kind of similar to that of, we're not providing the services, we're managing the patient pathways and managing, which organisation the individual goes to. There is a management agreement, which we have seen in some places. So, we've Manchester University and Pennine Acute over North Manchester Hospital, Guy's and Tommy's over Dartford and Gratian, the Northern Care Alliance. So we have various instances of that in terms of the providers engaging to provide management support, and then potentially even seconding personnel. But it still goes back to the whole joint management team approach, that you still have separate bodies that are making and must clearly make separate decisions. So they can support, and there may be a management agreement around it, but that doesn't necessarily integrate how you're going to provide the care going forward. So other multi-organisational group structures, and the ones that we're probably starting to look at a bit more, so collaboration or federation agreement. So a group of providers entering into governance arrangements for collective system decision making, albeit remembering each provider retains full autonomy for services that it provides. So taking a little bit from what we did, to be honest, with GP federations and trying to widen that out, that concept, and make it work on a wider basis. So you've got that with the Greater Manchester Provider Federation Board and the West Yorkshire Association of Acute Trusts. So that's a mechanism that could well work going into the future as we try to create integrated care partnerships. I think place delegation agreement is, one of the more interesting bits. So I mentioned the whole Croydon Health and Care Board approach. So one or more providers entering into governance arrangements with commissioners for the management of a delegated population, but notice it's about management. The actual functions of the commissioner are not delegated to the provider. But the clear budget is set, and that is much closer to probably what we're looking at in terms of integrated care systems. And I think people are looking at that a lot more closely now and trying to understand, all right, so how does this work? What are the nuances? What are the issues with it? Is there some way we can make it better? How has it actually worked on the ground? So, trying to get Matthew to tell you, all right, what are the problems you've had? And how has this all worked when you're effectively managing for the CCG going forward in place? So I think that's certainly one which you will hear more about. And contractual joint venture, which is something we have looked at. We've not actually used it yet in this whole scenario, but the concept is that you very much get people to work to a set of rules. So contractual joint venture is effectively about setting the rules of the game for you all to work together to deliver a contract. That's what we're trying to do with it, and to make sure everyone is treated fairly. So you generally will have the lead provider to hold it. The rules of the game will be fairly clearly set out, and the partners will appoint a board to act as a system integrator to make sure that the rules are complied with and everybody's treated fairly. So it does have quite a bit of governance around it, but is kind of enables more than one body. So place delegation agreement that we have in Croydon is really about one provider and one commissioner there. But when you have multiple providers, then contractual joint venture may be a route to use, especially if you have smaller providers. So you may want to have a very easy access and exit route for small providers, say in terms of social care or physiotherapy or whatever it is, that they don't have huge contracts to wade through, and that you have an easy route for them to do it. So that may provide an option. The other things we have looked at, corporate joint venture, looking at provider alliances, we really don't recommend them. We think they're too complex. We think there are too many unknowns. So what about the trust powers? What about VAT? And politically, we're not convinced they would necessarily go down very well. They work for something, so we've used them over pathology and things like that. But outside of that, I think it would be more difficult. And obviously, there's the single merged provider, which is the way that some systems may come together in due course, but I think is kind of along the route that, and it's inevitably, to be fair, something that as you come together, working under, either a contractual joint venture or, lead provider arrangement or alliance arrangement, whatever it is, you will at some point think about merger. It's a natural thing to do. But as I say, that does make things much easier, to be really honest, but something just to think about. So I am quite conscious of time. I think some of these are the questions we've looked at before. So organisational boundaries, I've spent a bit of time on, about each body being autonomous. The inability to delegate for FTs does create a bit of a problem. Removing that, to be honest, from the Act and stopping FTs being viewed as enterprises would be quite helpful, because it just takes away some additional issues they need to address. thinking about what FT's duties are now. So is it to promote the success of the FT and maximise the benefits for its members, or does that need to be looked at as well? And obviously, as I mentioned, we have to be clear on competition and procurement law as we go through too. This is more about making sure that you understand what it is you expect your integrated care system to do and what you are asking at place level your provider alliance to do, so that you're very clear over how they're going to work together and what the expectation is. And that brings us with 12 seconds to go where are we overall? So my own personal view, and I have to admit most of these are kind of my personal views, albeit drawn from the work I do across the system. So I think it's pretty clear COVID-19 is going to have a profound impact on the future delivery of health and social care services. To be honest, we have never been involved in so many digital technology procurements and changes to how major digital services are used and provided across the system. There is a huge amount of work going on over that in order to enable people, to actually have the ability to use the digital system to access health. So at a local level, rather than trying to get an appointment with your GP, you can go onto a digital platform. You can tell it, essentially into the algorithm, what symptoms have I got, and it'll start to direct you. Do you need to get a refresh prescription from the pharmacy? Do you actually need to go and get some physiotherapy? Do you need to see a doctor face to face? Can you see a doctor just over, a phone or whatever? Or should you actually be taking yourself straight to A&E because there's something more serious going on here? So there is a lot of work going on around those that we've seen. I think it's pretty clear legislative change is needed to enable the development of integrated care systems. And the question that people are asking, which I've already looked at, is this a top-down or is it going to be truly bottom-up? And so far we've done kind of a lot of bottom-up, but with quite a bit of guidance. Although it's interesting in that, if you don't do a top down, then somebody comes along and says, God, I wish they'd just tell us what to do. And if people come along and tell you what to do, then people say, why are they telling us what to do? Why can't they just leave us to make our own decisions? We're adults. So there is a bit of that goes on as well, which we just need to kind of look at what are the best solutions that are out there and how can they work within the system. The new guidance coming out is to support development and hopefully reduce some bureaucracy. Is what the intention is. I think the development now from an ICS perspective, certainly the work we're doing is moving away from commissioning and onto provision. How is that done so we can fulfill both sides of the equation? And the updated future vision, I think, is pretty clear that systems need to be clear about system and place offer to people in their communities. I think there will be a indication now that actually place should have an NHS lead to reflect the local authority lead. It won't always hit in exactly the same way, but at least then that should align how health provision and social care provision are met. And what is pretty clear is that access is key. So that whole duty to reduce inequality of access is pretty key to the way the system works overall. And I think that means that even without COVID, there's quite a lot to do. And it's trying to fit it all in, I guess. That's going to be key. But I would say, so I don't think, and I say this to all of our clients as well, I don't think there's one size fits all, but I think there's a lot of really good information out there that you can look at and you can think, do you know what? This will work within our system. We need it to work in a different way, but actually I can see how this operates without constantly trying to reinvent the wheel and change what's going on. So I would recommend that you look at the way other systems are working as well. And that's it.
Brilliant. Thank you, Gerard. So we're just conscious of time myself. I'll just ask one quick question that's come through chat and then have a quick minute if anyone wants to quickly ask any burning questions. The quick one which has just come through chat, Gerard, was which body would provide arbitration if, for example, there was a large-scale issue within a multi-organisational body?
So what we've done with that is in the integrated care system handbooks I've been talking about, we've addressed dispute resolution. and been very clear over whatever mechanism they want to use. So that doesn't, it's not just, it's not defaulting in the way that the Who Pays guidance does, where it's NHS England who are doing it. It is about looking at, okay, how are you actually going to resolve this and what are your mechanisms for doing it? And most of them will, be very clear that they'll go to mediation or ultimately to arbitration if necessary. So that is addressed in setting out how the actual system will work.